Hey, what's up, y'all? It's Dr. Italo Brown, emergency physician, and this is Med vs. Movie. Now, on the last episode of Med vs. Movie, we talked about one of the most crucial procedures in ED thoracotomy. Now, this typically happens in the setting of a traumatic arrest. It was a bunch of twists and turns in that episode, and so I feel like the Pitt has just basically taken the cake for being one of the best medical dramas to ever hit the scene. I think that, we're starting to see kind of like a renaissance in terms of this particular type of filming. And it's just smart, right? To use every single hour as an episode. So without further ado, we're going to talk about the next episode. I'm going to bring out a couple of the scenes that I felt were really compelling, things that I thought had good education, procedures, as well as a couple of the nuances that you maybe didn't catch. Just like every time I do this, spoiler alert. If you have not watched this episode, what rock are you living under? I mean, I just need to understand right now, like, why are you not caught up on the episodes? But if you haven't, stop, go watch it, return, and then we can get this thing going. Or if you just don't care and you want to go ahead and rock with us, let this thing roll, all right? Without further ado, check out the episode.
Moving in there! Ma'am, hold still. I can't help you if you keep moving your head. Get it fucking out! I can feel it.
Arthropod in the EAC.
So what we have here is a senior resident who is calling out to the attending that he's basically about to see this patient who seems to have what I would consider to be like an ESI level 4 minor complaint. He said arthropod in the ear, so we already know it's going to be something wild.
Good news or bad news first?
What's the good news?
Ear canal is
Ask for
numb.
the bad news.
Simple flush with saline will fix the problem.
What's the bad news?
You've got a dead bug in your ear.
Okay.
Cockroach.
All right, y'all, pause. So, I mean, he kind of like buried the lead by saying that there was an arthropod in the EAC. EAC was a code phrase that he said for external auditory canal. For most of us, we just call it the ear canal. Now, one of the most common things that you'll see in like an urgent care scenario or maybe even lower acuity zone in a hospital is a complaint like a foreign body inside an orifice. I don't understand why, but it sounds like arthropods just love to find ear holes. But in general, man, this happens, I would say, like, once every few months, you have a person who comes in, they've got something that's stuck in their ear. You get down in there, you realize that it's actually a bug. So the cool thing is that he actually kind of talks about some of the steps that are super important. Major concern for most people is freaking out and feeling pain, almost as if you get the sensation that it's moving. So I typically recommend going in with some type of agent that's going to kill the bug. So stuff like mineral oil. Sometimes people use lidocaine, maybe some like diluted hydrogen peroxide or just saline flush, something that's going to get that bug basically gone. Now, what I think is super unrealistic is the bug coming out looking like that. That is not how they look, yo. They look like this. In most cases, the mineral oil or whatever you use is going to kind of cause that arthropod, their skeleton, their exoskeleton or whatever to break down a little bit. And you'll see kind of fragments or it'll be like very thin and mushy. So I don't think that that's super realistic, but the presentation, the case, absolutely bread and butter emergency medicine stuff. You also want to have them follow up with somebody because a lot of times there's like a perforation behind that. Like the eardrum itself might not be intact. You might have to start them on antibiotics if there's concerns for an infection. So super common presentation, excellent use.
Wendell Stone, 52, chief rigger from Pitt Fest. Isolated trauma to the left chest when a speaker tower came down on him. Looks like multiple rib fractures. Pulse 110, BP 130 over 85, decent stats at 96, 50 of fent in the field. Got it?
So in this next case, it's almost as if they were reading my mind. I love lung stuff. I love different types of trauma. And so this patient was working, I guess, at a festival and a huge speaker just like landed on my man's chest. And so I don't understand what you got to be doing with the speaker for it to just fall directly on you, but people come in with this pretty frequently. And my immediate concern is like, yo, what's going on with the structures deep to the ribs? So let's watch it now.
How we doing, Mr. Stone?
Mr. Stone's my dad. It's just Stone.
No
My
abdominal
man's
tenderness.
talking. That's a good sign.
You want me to click?
I guess for now.
Stop. I want to hear from Dr. Santos. Isolate.
Hold up. I would be remiss not to say this. Again, this show is super, super accurate when it comes to these microaggressions, cutting people off, not letting them talk. 100% what goes down. I think it's crazy that she just got off an attending though. But shout out to her for, taking control of the room. That's what I'm talking about.
Focus, good stats and vitals. Excellent
Pause.
presentation.
So in her presentation, what she essentially shares is that this ultrasound has been performed. It's called an EFAST. You've heard me talk about a fast in previous episodes. The EFAST is just adding additional windows, looking at the chest specifically to see if there's presence of lung sliding. Lung sliding is like indicative of good, lung movement, making sure that there is no pneumothorax. And so she calls out hemopneumo, which is basically a code saying that there isn't presence of blood or a collapsed lung from what she can see on ultrasound.
Sir, I'm Dr. Garcia from surgery.
My man rocking that probe.
Not necessarily.
I like
no
it.
blood in the belly on fast. Okay. You got this?
They trained him well.
Abdomen's benign. CT chest, abdomen, pelvis with contrast. Which I trust way more than your ultrasound.
So she basically shares what the plan is going to be. Even though the belly's benign, think about other things that are on that side. So lower rib cage fractures can potentially injure the spleen, and you could have a splenic lac. So I agree with the idea of, based upon the mechanism alone, getting a broader imaging study like a CT, chest, abdomen, and pelvis, and not just focusing on what you can see as the main injury. Look at my man. It's kind of a little depressed a little bit. I like how they're giving you almost flail chest vibes, but it's not, entirely the case. There's like paradoxical movement of the chest. I like that.
But the crew doing the pudding.
The what?
The festival.
Bro, you ain't staying on top of
all
nobody.
the nerves going to the
That speaker was on top of you, fam.
Roll to the right. You'll be awake and pain-free.
Yeah, that's what I'm talking about.
Yeah.
A ton of intercostal blocks.
Nope, one shot. Serratus interior blocks down to T9.
Oh, yes.
In your crazy
Pause.
regional block.
I love this. This is like one of the dopest things to introduce. So you heard my man say that he wanted to be awake. You also think about how much pain somebody has to be in if they've got broken ribs, if they've had some type of large, heavy object land on them. And so obviously this dude's in exquisite pain. He's a hard worker. And so what other options do you have to give analgesia? And so to skip like opiates or fentanyl and Dilaudid and all these other medications and think more practically by introducing the concept of a regional block is incredible. Now, anesthesiologists, folks who work in pain, have been doing regional blocks for a long time. And in emergency medicine, we've started to kind of leverage our ultrasound skills to do these types of procedures at the bedside. So it's really dope that he kind of talks about the anatomy, saying that, these particular ribs will be all covered, meaning like they'll have, some adequate analgesia if he uses this technique, ultrasound, instilling some lidocaine and capturing it, that serratus anterior linkage of the nerves and numbing them essentially. That to me is like one of the bread and butter call outs of emergency medicine, something that we're doing now a lot more commonly. So super dope to introduce that concept and to give you all kind of insight around different mechanisms of pain control, especially as we've got like, opiate epidemic stuff happening and trying to create pain-free emergency departments, or rather opiate-free emergency departments. She remind me of me. I mean, not in that way, but specifically her pushing with one hand and got a phone on the other joint.
Just a little air leaking from the big bruise in your lung.
Yo, excellent. Pause. So he overhears the resident saying that he's got pneumothorax, and then something that patients don't do too often and should do 10 times more is directly on site asking the provider, what does that mean? What is a pneumothorax? And right on cue, she provides an explanation. This empowerment is incredible to have a show that's showing an individual how to pose questions, but also to have the courage and the general inquiry about what's going on with your body and knowing the language to use is incredible. She's correct. And shout out to my man.
Short of breath here.
Pain?
No, all that's gone.
Okay.
The block worked.
Wait.
Sats are down to 85 on 5 liters.
All right. So now we're concerned.
Some help.
My man said he's feeling more short of breath. His sats are down. I am worried about this guy. Like, I feel like this is progressing in a direction where his pneumothorax is increasing either in size or the pressure is increasing. And so something else has to happen.
His lung contusions need some help. Start BiPAP.
No. That's not what's supposed to happen, yo. So, all right. For everybody that's watching this, it's important to understand these different therapies and interventions that you can do, because while some therapies are, standard of care, some therapies can potentially worsen the problem. In a case of a person who has a pneumothorax of any kind, don't go straight to putting a person on BiPAP. That seems like one of the most, like mindless things to do. And I don't know if it's like to set up the next step, but there's like so many other things you can do up to that point. So I wouldn't just go straight to BiPAP. She said, you know what? Forget it all. I'm going straight to the joint. Bad idea.
What's going on?
Hypoxic to 78.
Just like we thought.
Systolics 82.
My man is crashing.
Ready. I should intubate.
He's about to leave Earth, bro.
Transfusion protocol?
No.
Oh,
Absent
no.
breath sounds on the left. Tracheal deviation to the right. 14 gauge angiocath. Now put him on a non-rebreather.
What are you doing?
Tension pneumothorax from the BiPAP's positive pressure.
Pause. A lot of stuff just happened and it's all good medicine. So the man had on the BiPAP mask, is forcing positive pressurized ventilation into his lungs, and is continuing to worsen that collapsed lung. Which wasn't really kind of articulated here is the standard of care in a person who's got a pneumothorax that's pretty small is to just start a non-rebreather. So give them 100% oxygen via non-rebreather mask, and you can often resolve some of those, because the lung will reinflate very gradually. Now, if you're putting positive pressure, that's just going to continue to worsen that differential and then cause, again, increased buildup of pressure inside the chest, which is why he talks about having tracheal deviation. So in the case of a tension pneumothorax, what you'll see is this, your trachea is going to push to the opposite side of the lung that's affected. Then now he's forced to act very quickly. The appropriate thing, as he's doing, is to get an angiocath, 14 gauge is typically what they use, and place it in the midclavicular line, second intercostal space. For all of y'all who are taking exams, want to do emergency medicine, I just gave you 1 point on the board. I just gave you the answer, yo. It's always going to be midclavicular line, second intercostal space. In most cases, you follow up with a chest tube because it's now got to resolve, and this is just a temporizing measure. Anytime you do a needle decompression, it is not the solve. It is just an immediate fix to release the pressure. And there's the hiss.
Hear that? Who the hell ordered
Music
BiPAP?
to my
Garcia?
ears.
No, his sats were down. I did.
You did. Without running it by me.
All
Can I
bad.
put in a chest tube?
He doesn't need a chest tube. He needs a pigtail catheter, and I'll be doing it.
Sats and pressure both coming up.
All right, so I mentioned pigtail catheter. That's the chest tube, very small, appropriately named because when it's in the chest, it coils up, looks like a pig's tail. But there's something bigger here that we got to address. Obviously, in every episode, this particular interaction is contentious, and she kind of is cavalier, or rather what we would call like a cowboy or cowgirl in the ED. She tries a lot of different things and is not really giving complete respect to this chain of command. And so I think that, this is one example of where her actions were detrimental to the patient. It didn't follow standard of care. And so if I'm, the senior, you can say that this is a person who's being subordinate, either escalated to the attending, or you can address them directly, which I think this show is continuing to demonstrate. Is like, we're going to directly address this. I wouldn't do it in front of the patient. I think that kind of is like distraction, especially in the setting of somebody who is like potentially unstable. So outside of the room, I'm gonna say like, hey, in the future, you have to run things by me. Like, there is no indication for you to kind of like go rogue and make your decisions without running it past a senior resident. That chain of command is established for a reason. It's so that things don't get, mucked up, and so that people don't have these bad outcomes. If I'm the attending, like I typically do, once I hear that this happened, I'm wondering whose fault it is. Obviously, you can't go straight at the junior resident. You got to look at the senior resident and say like, how come you're not effectively kind of coaching, managing, or nipping this behavior in the bud early so that you don't hurt or harm patients? A lot of layers, and the show is hitting them, every last one of them, relentlessly. I love it. All right, we just talked about needle decompression, pneumothoraces, pigtail catheters being placed, all of that good stuff. Now we gotta switch gears to something that I think is a lot more common than a pneumothorax in the emergency department, especially these days where we have limited access to mental health services and we have so many different individuals who come in with toxidromes or rather are intoxicated on some type of substance and are metabolizing. They got this guy on this episode, they call him the Kraken. Also Clash of the Titans stuff in Greek mythology. Funny that his name actually sounds like Kraken. But what you're about to see is them do what's called a adding chemical restraints or doing a chemical sedation based upon his agitation. There are different schools of thought around this, and I want to make sure that I honor our psychiatry colleagues as well as all of the different services that work to protect patients, provide standard of care, and also appropriately treat and manage these conditions. What we typically desire is de-escalation. Is the patient redirectable? Is the patient able to kind of follow some of the recommendations and things and the protocols that are established to protect them? Often this includes some type of like chemical or medication sedation or giving medications that are, I would say, considerably more humane and approved for this type of treatment. But when that stuff fails, this is what you get.
You're coming with me. Okay, we have a quorum. Med's finally here?
Yep. Guy's got some energy.
Let's do this. Donahue, right leg, Larry, left leg, Kim, right arm. I call left arm. Perla takes the head, and our young man here will inject.
My man is
Clear?
going off.
Yeah. Pulse ox.
Right here.
Good luck.
I am injection to the mid-anterior left thigh. Everybody ready?
Yo, Whitaker, you playing
All
the
right,
ball?
pause. I will work with this nurse any damn day of the week. Any day of the week. She is a boss. The way she kind of just like quickly assigned all of those different roles, made sure to give, the youngest or the resident kind of the safest role in the entire, I guess, consortium of people who are about to go in and attempt this sedation is dope. She makes sure that the experienced individuals are already aligned and that it's done in a manner that protects both the faculty or staff members as well as the patient. Major props.
Play any ball?
She like that. I like it.
Dodgeball.
She like that.
Of course, football. Yeah, some peewee. I was actually a pretty good kicker. Not helpful.
You know he ain't play no
Look,
damn football.
Larry and I gonna block for you. Come
We
in,
all
right
looked at this
behind
man and know
us.
he ain't
Split,
playing no
go
football.
for his legs. You go right up the middle. End zone, baby.
Yeah, got it.
Okay. You ready? One,
My man couldn't even get the handshake right.
3. Okay, Mr. Krakow,
Yep.
yeah, we're here to help you.
Okay.
We're here to help you.
Ooh.
What do I do?
Golden shower. All right, pause. Yo, you have not lived, or rather, I don't even consider you a person who has been properly indoctrinated to the culture of the emergency department until some type of bodily fluid has hit you. The prayer is that it's never urine, but it can be urine, it can be blood, vomit, feces, whatever, and what I really appreciate about this scene is your man didn't stop. Nobody stopped, because once you're in there as a team, the last thing you want to do is act as though you're so grossed out that you don't complete the task. The task is super important. It protects everybody. And when you start to drop that task, people get hurt. Obviously, you can change. My man then got multiple different types of fluids on him already. The dude should basically be a scrubs factory at this point, but it is absolutely accurate to have this type of a moment. I've seen patients use urinals like hand grenades and throw them up in the air and let them splat on the ground, and then everybody just gets hit by urine. I've seen people, like I said, toss feces. All of this stuff occurs, and you have to keep in mind that whether it's intentional or unintentional, it doesn't change the fact that you have to deliver the best care possible to this patient. And in this situation, using the chemical restraints, in addition to, as you see, he's got soft restraints on the wrists, is essentially the best care that they can deliver at this time. Sorry for your man. He got hit with the waterworks. Next time, I guess he's gonna watch a game of football and follow the blockers. If you all are enjoying these episodes, I'm talking about these breakdowns that I'm doing, make sure that you like, comment, and subscribe to Med vs. Movie. All right, y'all. This is continuing to build. I'm enjoying each episode. I feel like the learning is so natural. I feel like everyone who's watching it is excited about what's happening next, and the field of emergency medicine is getting its proper due. All right. Make sure y'all pull back up for episode 5, all right? Dr. Italo Brown, signing out.